Dr. Manpreet. Let's have the Phakic IOL.
Yes.
I think I'll say dynamics inside the anterior chamber with these lenses. Dr. Shreyas Ramamurthy, and he's the dynamic person doing a lot of surgeries from entire south, north. You can imagine, and he's a very good teacher for all of us. Dr. Shreyas, please.
Thank you so much, sir, for your kind words, and thank you, Dr. Manpreet, for including me in the course. Phakic IOL surgery is possibly the simplest surgery that any anterior segment surgeon can perform. However, there are small situations where we can run into trouble, and I'm trying to highlight some of these challenges. The first and most common thing that we can have, especially with ICL, is that there can be a small tendency to reverse. So when that happens, essentially even when you're almost halfway in, you can stop, and after you stop, you can take a small, before you continue pushes inside, you still have full control over the lens, and you can rotate and twist your hand to bring it back into the right position. And you can also use the second instrument to slightly, once this has been, now I've tilted it and it has come halfway, and I can just push it, tap it on this side, and then it flips. So if it is, of course, opened completely in the opposite direction, it's better to remove it and then implant it again. But in these cases, when you're able to twist it and make it halfway right, you can just nudge it, and these patients do quite well. One thing we must remember is these are hydrophilic material. Even a little touch on the cornea will produce corneal edema. So it's important that you are very conscious of that, and if you are even running into any trouble, don't hesitate to remove the lens and implant it again.
Sir, just to stop, like suppose you're doing a hydro implantation, like many people are propagating that. Can you do the similar manipulation in those cases also? Or opening will be faster than the viscoelastic use?
The thing is, sir, if with the hydro, the opening, yes, can be faster, but the other small challenge is that the jet from the hydro itself reduces our ability to control as compared to the second instrument in a viscoelastic filled eye. So that's the small challenge with hydro implantation. However, with the Indian lenses like the ICRL or the IPCL, because of the way the butterfly cartridge is, it's very, very rare that it flips. With ICL, while pulling the lens forward, if we are not perfectly parallel, we may end up slightly tilting the lens one side or the other, but seldom happens with the Indian lenses.
Yeah, thank you.
Yes, sir. The other challenge which we can have is really the variable vault, that we can have a low vault or a high vault. Now again, unlike a toric IOL, a toric phakic IOL almost never rotates. I mean, if you have, unless there's some parallax error, if you have implanted it in the right side, it does not rotate. So if it is rotating, we must be very conscious that whether this is a small lens for that eye. Sometimes your vault may be adequate. You may have a 300 micron vault, still the lens may be rotating, and this is essentially because for that particular sulcus, this lens is not adequate, and in those cases, or if you have a low vault on ASOCT preoperatively itself, we have measured, then no point in rotating these lenses. It's better to go ahead and exchange them. So exchange again is very simple. So all that we have to do is just basically the reverse and just dilate the pupil adequately. And this is a slightly older lens, so I'm making the incision again. You just keep one haptic pull, one haptic up, and use a hand over hand technique. Just pull one side and then use the other forceps and take it out. It comes out very easily through the same 2.8 incision which you have used for the original implantation, and then you can go ahead with the subsequent implant and use a slightly larger lens and achieve an adequate vault. Again, if it's a low vault or it's the older lenses where you didn't have the central hole, then you can develop an anterior subcapsular cataract over time. So just stain these lenses, because some of these capsules can be a little more fibrotic. So the rhexis can be a little more challenging than in a normal video. Again, removing it is very easy. This is I'm showing this that you can use a smaller forceps to initially grasp it and bring it out, and then a hand over hand technique with a larger forceps make it a lot more elegant. The rhexis is the only part which you need to be conscious about. Otherwise, it's usually a soft cataract and it's a very simple surgery. High vault is the bigger challenge, and these are pain. You have to remove the lens immediately. There are patients with a slight 1,100 micron vault where the ACD is quite adequate. The periphery angles are still open, and you can safely observe these patients without any difficulty. But in case of keratoconus patients, because of the central cornea being steeper, you may end up having a falsely higher central anterior chamber depth. Anterior chamber depth measurement is right, but for that particular eye, we would end up choosing a larger lens than what we would have chosen if the patient did not have a steep cornea. This can happen even with, I've had with patients who have high astigmatism as well, regular corneas with very high astigmatism, as well as with keratoconic patients, where you can end up having a high vault which leads to a optic capture. It keeps tending to capture through the optic, and this can become a challenge. This leads to lens tilt and therefore reduces the quality of vision. So again, you'll have to here exchange with a smaller lens. We've done a comparative study where we have looked at patients with centered as well as decentered cones, low and high astigmatism. And as long as the patient has a very good best spectacle corrected visual acuity, this is an excellent option in keratoconus patients. But the only thing that we need to keep in mind is remember that the sizing ideally should be one size lower than what you would select for a similar patient, especially when the Kmax is exceeding 50. If it's a very early keratoconus, 46, 48, you can probably go ahead with the same sizing. But anything beyond 50, just go one size lower, and these patients will do adequately, very well. And we know with the centroflow lenses, even if you have a vault of 250, 300, it's perfectly fine, and they do very well in the long term. Again, iatrogenic keratectasia is another indication where you can use these lenses. In any of these procedures, whether it is keratoconus or post-LASIK ectasia, you can first regularize the cornea either using an intracorneal ring segment, improve the best spectacle corrected visual acuity, or you could even do a topography guided regularization. This is one such patient whose pre-op BCVA was only 618, but post topo guided treatment it improved to 6.9. And these patients, once they are happy and comfortable with the spectacle corrected visual acuity, and many of these have a significant anisometropia also, wherein one eye is a very early ectasia, other eye is a more advanced ectasia. They are unable to wear spectacles because of the higher degree of anisometropia. In these situations, a phakic IOL is an excellent option. Again, one other example, little more advanced keratoconus, where the vision improved significantly after intracorneal ring segment. The cone was much more central, much more repeatable readings, repeatable subjective refraction, and these patients do extremely well even later. Again, you can use it post-DALK as well. I would not want to use it post-penetrating keratoplasty, but post-DALK, this can be a very good option after all the sutures are out and your refraction has been stable for quite some time. You can then go ahead and correct the residual refractive error with a phakic IOL. And again, you get fairly consistent and repeatable results. And the only thing which we need to keep in mind is don't go with the topographic astigmatism because that can be a little more challenging. Go ahead with the subjective axis, use the subjective refraction when you have a repeatable subjective refraction. And I always give a glass trial, never go ahead with the phakic IOL directly. Ensure that the patient is comfortable with the best spectacle corrected visual acuity, because that is really what you are going to correct with the phakic IOL. You can also use it in pseudophakic eye, where either because of extremes of ametropia, you don't have IOLs of that power and the patient has a residual error, or there is a biometric error which has happened. It's a simpler procedure than exchanging the lens, especially if the capsule is already fibrous and it's been some time since the surgery has been done. And this can essentially being used as a add-on lens or a sulcoflex lens, where you're basically using a phakic IOL to correct the residual power. And again, these patients also do very well. The calculation is very simple, and you can just go ahead and implant the lens for the residual refractive error. Again, being a pseudophakic eye, the anterior chamber depth is usually very deep, and vault and other issues are really not there. And again, since these lenses are essentially hydrophilic material, if you have a hydrophobic lens in the back, bag, it really makes no challenges. These are again not situations which we encounter too commonly now, but in case you have a patient with an anterior iris clip lens which has been done earlier, and we know that some of these patients progressively the specular count keeps reducing. So rather than waiting for decompensation to happen and then doing a surgery, it's better to preemptively remove these lenses and exchange with a posterior chamber phakic IOL. And we have a few of these cases, old patients who are on serial follow-up. We see that the specular count is dropping. Then you go ahead with the ICL, and then the count subsequently stabilizes and you don't have any further drops. I'll just end with this quick video. Again, we operate mostly on very high myopes in these situations, and both the corneal as well as the scleral rigidity can be low. And as you can see here, this brittle cornea, though not a very common situation, the incision is tending to extend on both sides. Even the side port as well as the main port is tending to enlarge. So just inject the lens. All we have to do is be calm, suture the port, and then subsequently you can go ahead. And despite this challenge, this patient did quite well. But this is something to be aware of. This patient had fairly normal corneal thickness, no other abnormality on topography. But being a high myope, it is just that this patient can be associated with a brittle cornea and a lower corneal rigidity. This is one rare situation which can happen with even with phakic IOL patients, more difficult to address because doing a pupilloplasty in such eyes where already there is a crystalline lens and a phakic IOL becomes quite challenging. Some patients, when they come with a slightly more intense inflammation, these are young patients, and if they have more pigment dispersion in the initial period and are coming with this slightly higher amount of inflammation, increase the steroids, but I would say let's to avoid a cycloplegic or avoid giving homide, because sometimes they end up with this mid-dilated fixed pupil after that cycloplegic has been used. Thank you so much for your kind attention. Thank you, sir.
Thank you, Shreyas, for showing such a wonderful application of phakic IOLs and challenging situation also. Just for remembering my early days. One of the first ICL meet happened in 2004 in UK, and there was one surgeon from Russia for a very high bolt. He prolapsed the lens in the anterior chamber. He cut the haptics, the flanges, and implanted the lens back again to. Would that be a good option rather than exchanging the lens?
I think rotational stability would be very questionable. Maybe a spherical lens could be considered, sir, but in a toric lens, I think we'll better to explant and reimplant.
Maybe I think 20 years back that was the only option people had. But he rightly showed you have so many options, and these lenses are very safe and give you a very nice optical quality also. Thank you, sir.